Okay, I think we're just past the hour. We're like 5 after 9, so or 5 after 4 in Athens. So I see several people are here. So why don't we begin? And just so I'm sure other people need to get on with life after our event is over. So let me start by saying sort of good morning to everyone from New Jersey, or good afternoon if you're in Athens. So καλημέρα σε όλους και όλες από το New Jersey και την Αθήνα. Θα συνεχίσουμε στα αγγλικά, αλλά για οποιονδήποτε έχει κάποια ερώτηση που θέλει να υποβάλει στους ομιλητές, παρακαλώ είτε σηκώστε το χέρι σας και ρωτήστε, είτε υποβάλλετε το ερώτημα μέσω του chat στο Zoom. I said we'll continue in English, but for anyone that feels more comfortable raising a question in English, feel free to do so by raising your hand in Zoom or by posting the question in the chat function in Zoom. We are thrilled to welcome you here at this first joint symposium that Rutgers and Harokopio are co-hosting in the context of a broad array of activities we have begun working on together and of a partnership that has been in some ways renewed, I suppose, or expanded through the International Academic Partnerships Program Greece, IAPP Greece, for those of you that might, and many of you probably haven't heard of it. Academic Incubator Program sponsored in 2020 by the Greek Ministry of Education, the US Department of Education, the Institute of International Education, and several other organizations, including Fulbright and other institutions, and is designed to promote international collaboration between US and Greek institutions of higher education. And so I'm, as you can see, Matthew Matsaganis. I'm an associate professor at the Rutgers University School of Education and Information, and the co-lead of Rutgers IAPP Greece initiative. My research, if you will, focuses generally on the role of communication as a determinant of health and health disparities, mostly in urban communities, but also on how the well-being of neighborhoods can be improved, transformed through communication-centered interventions. My co-lead, who you'll probably see here, one of these windows, Professor Riva Talger-Decker, is a professor and chair of the Department of Clinical and Preventive Nutrition Sciences and the Associate Dean of Global Affairs at the School of Health Professions at Rutgers. And so at this point, I think we should acknowledge and thank the leadership of our Rutgers schools, our deans, Jonathan Potter and Gwen Mahone, as well as our academic and research associate deans at both our units. The third important contributor to Rutgers initiative is Rutgers Global, which is the unit on campus that facilitates and supports all of the university's international endeavors. And this particular initiative's objective is to advance health communication, research, education, and practice across the health professions, both in the US. At this point, and before we talk more about today's event, I'd like to pass the mic over, metaphorically, to Harokopio's rector, Professor Mara Nikolaidou, who would like to welcome you, and I'd like to ask her to give you Harokopio's perspective on all of this.
Thank you very much. Good morning and good evening to all of you. Let me say a few words about Harokopio University. You have to know, if you don't know about us, we are a public university and we also are a research university. 1/3 of our student populations are postgraduate students and PhD candidates, and this is the higher rate for a Greek university. We are also ranked among the top 3 universities nationwide as far as research outcome is concerned. I mean, in terms of citations and publication per researcher. So we are very proud that we have actually accomplished excellence in research. Our main fields of research are health, technology, and the environment. And we have strong collaborations with international institutions in Europe and the US as well. We have fully accredited programs. All our programs are fully accredited, and the university as well, according to EU regulations. And we may actually provide international degrees. We have a very nice collaborations with Rutgers University. And I have to say, I'm very, very happy that the first MOU I had signed 5 years ago, in the beginning of my term as director, was with Rutgers University. And we had the opportunity to actually have a group from colleagues from Rutgers visiting here in Athens. Riva was in this group. And I hope we will be able to meet in person soon as well. The outcome of this collaboration was a study abroad program. It was actually programmed to start last year, but the coronavirus made different actually plans for us. Yet we believe that we will have the opportunity to have this program maybe next year or the year after that. And this was actually in the area of Mediterranean diet. Taking up the initiative of the Ministry of Education a year ago, the international collaboration program with universities from the US, we had the opportunity to launch this initiative as well in regards of digital health and medical communication. So I'm very pleased that we have organized this electronic event. And I would like to thank Riva, Matthew, and Christos from Harokopio's side for organizing this event. I hope that we will be able to exchange our projects and ideas, research ideas on these subjects, and maybe promote common research projects and mobility opportunities for researchers and students as well. I have to say, actually, I'm very, very happy to participate in the event, actually as a researcher as well, because this is close to my research interests, as actually I am the faculty member of the computer science department, and my expertise is on distributed systems and health application as well. So I'm very happy to welcome you all in this event. And I hope that we will actually achieve a fruitful discussion and some concrete results. Thank you all very much.
Matthew, you're muted.
I was muted. So thank you very much, Mara. I must say Riva and I are very excited about working with Harokopio, one of our key institutional partners, as in the context of this IAPP Greece initiative that we're leading. As one of our joint activities, the e-symposium series is designed with several goals in mind. I won't go through the list. I'll just mention that we want to begin to address some pressing health-related issues that populations and communities both in the US and in Greece are facing. That, of course, includes the topic of today's conference, if you will, on employing technology to improve health assessment, health communication, and healthcare delivery. It's an issue that is complicated, is also new and exciting. It cuts across both our countries, and the COVID-19 pandemic has made us all the more aware of it. And so today's event is sort of the first step in developing our understanding of these issues in both countries. We're talking about the ways in which we might, what we might do in the future to maximize the potential of technology in healthcare delivery and communication, but without exacerbating existing inequalities across populations with different sociodemographic profiles, with different levels of health and digital literacy. In fact, it would be great if we could begin thinking about ways and develop ways to which we could employ technology to in fact eliminate such disparities. And so that's sort of a goal I think it's worth pursuing in the future. The last thing I'm going to say is that we want to create this forum to discuss issues that are salient to health communication, and health professionals, researchers, academics, and policymakers in both our countries. So we want the questions of our discussion after the presentations to help push the conversation forward and force us to consider what we need to do next to more effectively address the health issues related to communication and technology. So I'll stop there with the introduction. I want to give you sort of a quick run through the agenda. We have 5 presentations that are going to be given. We're going to begin with, so I have my list together here with Professor George Dimitrakopoulos from Harokopio. While I ask him to set up the share his screen or his PowerPoint on our screen here. I'll mention that each presenter will have about 11 minutes to talk. My colleague Riva will keep time and give our presenters a 3-minute notice and a 1-minute warning before their time is up. Please hold your questions until we're done with all presentations. And later, after everybody has presented, we'll have a chance to hear from a reaction panel. These are faculty from both our schools that will help us kick off the conversation, but anyone in the audience should feel free to post their question, raise their hand to ask questions at that point as well. Before George goes and presents, I'm going to ask Christo Dio, our co-organizer here from Harokopio, to give a brief introduction to George before he presents.
Thank you, Matthew. Our first speaker is Dr. George Dimitrakopoulos. Dr. Dimitrakopoulos is an associate professor with the Department of Informatics and Telematics of the Harokopio University of Athens. He's the author of 3 books, as well as more than 160 publications in international journals and conferences, while he has been involved in numerous internationally funded research and development projects. His research interests include the design and development of strategies for the optimization of wireless networks based on cognitive networking principles, as well as the design of intelligent transportation systems and novel ICT healthcare applications. George, the floor is yours.
Well, thank you very much for the introduction. First of all, you'll see that I have 2 accounts. I had a problem with my camera in the first account, so I have another account joined with my name. So I thought I'd give an overview presentation to let you know what we have been doing in our team in the area of digital transformation, how healthcare can benefit from this digital transformation, and how AI tools and methods can benefit healthcare. So first, I give a few words on some basic definitions around the digital transformation concept, then a brief overview on healthcare, and then I will talk on the role of ICT and especially AI in healthcare with some research findings and some challenges. So as a definition, we all know that the digital transformation is about the increasing utilization of ICT and related tools and methods in the industrial world. This can bring or has brought already about innumerable radical changes in the industry as a whole, and the introduction of the robots that have gradually replaced or collaborating with humans in several manufacturing processes. As a result, of course, the productivity levels have been increasing, cost levels have been decreasing, and there are, of course, another number of factors that are being taken into account, such as trade barriers or the desire of customers for shortening delivery times, as well as other social, ecological, and economic responsibilities. Moreover, what's more is that the COVID-19 pandemic effect has changed the way that we are thinking, as Professor Matsaganis has already said. There are potential risks of global supply chains, and the rationale of exploiting cost advantages has been revised. There are still a number of issues to be tackled or to be confronted in terms of the digital transformation in order for the digital transformation to be completely realized. Those include the agility, the complexity, which has to be decreased, the costs that have to be revisited, let's say, as well as the fact that up to now, there are slow digital transformation acceptance rates, and those rates must be somehow accelerated. And there are certain differentiations on a per sector basis. What is the way forward and how digital transformation can be boosted, as we believe? We believe that digital transformation as a whole can be boosted through artificial intelligence tools and methods. We see AI as a physical continuation of natural intelligence, considering that the natural intelligence is the intelligence of the human being that has been evolving and developing over millions of years, includes the brain in combination with our sensors, eyes, ears, and so forth. So since AI is a physical continuation of natural intelligence, it's believed that it can boost digital transformation It can offer responses to new situations and constellations popping up unexpectedly. It can accelerate adaptations, provide a priori configurations of complex systems, increase the quality levels and the productivity, as I already mentioned, as well as decrease the defects and the error rates associated. How healthcare can benefit from the digital transformation is now what we should see. First of all, the state of play in healthcare at a worldwide level is something that we have been listening to and that we have been discussing since over 1 year a lot. So there are budgets that are limited in terms of healthcare and that are different in the overdeveloped or in the developing countries. And once more, the COVID-19 pandemic has made obvious that it's quite important, that it's extremely important to address healthcare issues, and has changed also the priorities for addressing those issues. This has brought about increasing expectations from the medical sciences. So there are several new questions that are being posed that require new answers. Those include the a priori diagnosis of diseases, the prevention of diseases, and of course, their treatment, which might have been previously not possible. There is also discussion about how to access quality healthcare regardless of a personal condition or location. There is discussion on how to select the appropriate resource from anywhere at any time, as well as how to provide patient management technologies. We certainly believe that the answer is, again, digital transformation. So we are confident that ICT can play still a very important role in healthcare. And as an example, I have thought to mention here the cognitive system. So a cognitive system can retain information from previous interaction with its environment, transform gradually this information to knowledge and experience, and plan its future actions accordingly. Of course, networks, wireless systems take advantage of specific technologies when we're talking about cognition, but the idea is the same. So, for example, in a network or in a system, we observe the environment in order to monitor potential changes. And then based on those changes, we orient the networks or the devices or the system's behavior, taking into consideration those changes, as well as previous knowledge and experience from previous interactions of the system with its environment. So we are talking about an adaptation of the system's behavior based on knowledge and experience. But this is exactly what is done also in the diagnostic treatment cycle. When we visit a doctor, we inform the doctor on our historic data through our electronic health record or through discussing with the doctor. Then the doctor observes tests that we have taken or what we are taking in terms of pills or anything like that, and then he or she orients somehow and decides upon an appropriate treatment of our potential disease or anything. So this is again cognition. This is again something that reminds us of AI, because it's the fundamentals of AI in terms of how we can benefit from our past, how we can benefit from our knowledge, how we can make ourselves more intelligent in taking decisions. Of course, you see here that I will not go through all these, but there are, of course, already a number of AI-related tools and methods in the healthcare sector. But there are, of course, several issues that are yet to be confronted. For example, data sensitivity, how we can preserve privacy within machine learning, which is one of those AI tools and methods that healthcare is already using, how we can train neural network models, again, in order to address different types of problems. So there are several issues that are already being considered in the context of AI in healthcare, but again, there are several issues believed to play an important role in the future. One of those is AI-enabled personalized monitoring. Of course, another one is the point-of-care diagnosis. The personal health systems that we are talking too much about them are still not in place in most of the countries worldwide. Another area of research is minimal invasive and precise systems for early diagnosis and management of diseases, as well as mental health and artificial organs. In all of those areas, AI can play a very significant role because it can bring about a lot of benefits. It can provide new methods, as I said, for diagnosis, prevention, and treatment of diseases. It can, most importantly, reduce the time that the patient spends in ICUs, and this is extremely important, especially in the COVID-19 case, where we see people aggregating in ICUs and doctors trying to make their time shorter there. And of course, tailored-based patient monitoring. So there are direct health benefits, but there are also lateral, I would say, benefits, such as the fact that AI can strengthen the industrial competitiveness, especially in the health sector, through the development of, for example, wearables based on AI or anything like that, as well as it can improve innovation capacity and integrate also new knowledge, for example, in AI tools and methods. As I said, and as also Christos said, we have been working in several European projects. Some of them are here, not only European, but also European. We have been trying to make some publications related to exactly this, how we can help healthcare benefit from the digital transformation and from the use of AI. And this was just an overview of how we see the overall sector of healthcare and how AI can benefit healthcare or can influence positively healthcare. Of course, there are several other things to be discussed. There are even more technical presentations that follow mine regarding specific healthcare issues. We would like, of course, very much to establish a very nice collaboration with you. So that was all from my side. Thank you very much for this, and I'll be happy to collaborate with you. Contact me whenever you want on that. Thank you very much.
Thank you, George. That was a great overview of a clearly emerging, ongoing, in a field emerging on an ongoing basis, if you will. And I think my colleague Vivek Singh's presentation is a good follow-up to that. So Professor Vivek Singh, he's the founding director of Behavioral Informatics Lab and associate professor at the School of Communication Information at Rutgers. Before joining Rutgers, he was a postdoc researcher at the MIT Media Lab. His work has been published in multiple well-known publication venues, including Science, and has been covered by popular media. Without further ado, I'd like to turn the mic over to Vivek to share some of his work with us. Vivek, we're ready for you whenever you are.
Thank you, Matthew. Thank you, everyone, for joining us. It's my pleasure today to share some of the work that we have been doing together in the lab that I lead here at Rutgers. It's called Behavioral Informatics. And I could spend hours just brainstorming with you and discussing you about the name itself. But for the purposes of our discussion, it's at the intersection of human behavior and information technology. So we use information technology to understand human behavior. Also, we try to understand how information technology impacts human behavior. So there's a cycle, the interconnection between human behavior and information technology is what really excites us, and this is where we focus some of our energy. So for the purposes of today's discussion, I would highlight two studies. One of them was a little bit in the past. We called it the Rutgers Wellbeing Study. The data for this was collected in 2015. And the idea was to study if there are interconnections between social and mobility patterns. And I'm a big fan of mobile phones. So this is a device which has more penetration than any other device that we have seen in the past. We carry it on us all the time. My phone knows a lot about my social connections. The phone knows a lot about my mobility behavior, and it's almost always on. So traditionally, there has been a lot of literature connecting the way we walk and the way we talk with health and well-being. So we wanted to study this from, let's say, a mobile phone or a data-driven perspective. So for about 60 participants, for a period of 10 weeks, we collected data based on a mobile phone app about the locations that they were visiting, about their communication patterns. And we were trying to see if that has some predictive power over things like general well-being, self-esteem, mental health, and so on. So well-being understood in a broader sense. We kind of then siloed and looked at different facets of it, all related to well-being, including things like mental health. So does my phone already know a fair bit about my mental health? Traditionally, you would need to go to a doctor's office to get an assessment. People have stigma, people are lazy, people have insurance issues, all those kind of barriers which are there in getting like a Fitbit equivalent of mental health. We were trying to see if automated data collection and data analytics, machine learning can help us kind of reduce some of those barriers. So we tried to do that for mental health. We did something similar for trust propensity, something similar for cooperation propensities. And the work, I'll point you to the different venues where it was published over some time. Just to give you one vignette of those kinds of works, let's focus on phone-based assessment of mental health. And for this particular study, our research questions were as follows. The first one was, do certain mobile phone-based features have intrinsic associations with a person's mental health level? And the second one was that if you combine all these data and data analytics techniques, can you build automated predictive models for an individual's mental health? The methodology was like this. We built this app. We called it the Rutgers Wellbeing app. We recruited participants. It was open to everyone. We ended up with a lot more representation from college-age students. They installed this app on their phone. So through call logs, SMS logs, location logs, over a period of time, we were trying to get an understanding of their behavior. We also asked them to fill some surveys, including demographic information, also including things like this MHI 5 scale. This is what is traditionally used by a nurse or a doctor to do a triaging. These are not diagnostic per se. They are more like a triaging step. So during the past month, have you been a happy person? Did you feel calm and peaceful? Were you nervous, downhearted, blue? And you get the idea. So these are the kind of questions. We wanted to see in future, is there a path that we don't have to fill up these surveys and our phone kind of automatically approximates this, at least for the triaging step. The more detailed analysis obviously still is purview of the doctor or the medical professional. So this was a 10-week study. We had about 60 people who finished the study, 45 of which who had all these data that we needed for this particular like branch of the study, out of which there were 30 males, 15 females, and these were the only two genders self-reported. The most common age was 16 to 29. On average, a person made about 400 plus phone calls over 10 weeks. The MHI score average was about 72. So we had like this rich array of data, over 20,000 calls, 2 surveys per participant, and we started seeing if there are some patterns, some trends in that. And to understand this, we tried to create some features out of our phone log data. So these were driven mostly based on empirical results, as well as some theoretical rationale. So for instance, social capital as a construct has been associated with well-being. Social capital as a construct has been associated with, well, communication patterns. So we wanted to see if those dots you can connect together to see if different types of features would have some impact. So we looked at features pertaining to call volume, the interaction dynamics, the tie strength, strong ties, weak ties, how you were spending your time across them, diversity and novelty in contacts, temporal rhythms, and things like that. Then we tried to see some interconnections. I wouldn't go into all the details, but what we saw was some of the features associated with having higher mental health scores were a larger call count. No surprises there, like the social capital rationale that I was talking about. Some of the things that we didn't quite really expect or think about were things like call response rate. So call response rate was, if you got a missed call, how likely are you to respond back to it? And we found that to be positively associated with higher mental health. Again, there's no causality here. In fact, we don't even know the direction, right? Maybe it is people with higher mental health are willing to make those calls, or is it that it's the directionality of it is the other way? We don't know the answer to that quite. One of those features associated with lower mental health was caused to weak ties. Again, weak ties were defined as proxy as your less communicated ties. But again, the relative distribution of the time varied across different people. And we found that those who spent more time with their weak ties on a relative scale, they had a slightly lower mental health. Now, instead of individual connections, we tried to see if we could put all these features together into different kinds of machine learning approaches. We tried some of the standard approaches like logistic regression, naive-Bayes, random forest, and so on. And jumping directly to the results, what we found was that phone log-based features, if you were to use random forest, would give you about 80% accuracy at median level split. So we split people at the median level as above average mental health score or below average mental health score. And we got about 80% accuracy with that. Surprisingly for us, demographic information added on top of those phone log features didn't really help us much. Maybe those
3 minutes remaining.
Maybe those phone log features were highly correlated with these. Maybe there are other explanations for this, but this is like an example of the kinds of findings that we were able to obtain. Now, obviously, there are a lot of limitations for this study. It's not quite accurate enough for healthcare yet. It was merely a triaging step. We need to understand the context. There are questions around privacy, the homogeneity of the sample, the gender bias in the sample, and understanding the algorithmic aspects of it, the bias across different genders or things like that could be a research study in their own right. So we are cautious in generalizing the results to a larger population, but this is again food for thought and opening. It motivates further investigation in this direction. And we've been doing some of that. For instance, we've started looking at the question of fairness across different genders, and our the default mechanism, the one which we reported in that paper, it had 80% accuracy, but the performance level was quite different. If you would notice in this first figure, for the two genders, it was like 90 for one gender and about 67 or 68 for the other. So there was a significant gap. What we were able to do with different kinds of algorithmic debiasing or bias reduction techniques is try to reduce the gap. Obviously, that comes with a trade-off that the overall accuracy also went down from 0.8 to about 0.76, 0.77. This is still work in progress. We are trying to improve on both aspects, the accuracy and the fairness. And lastly, as I mentioned, the 2016 study was a while ago. So we redid a newer version of this, which we call the Rutgers Wellness Study. We collected the data earlier this year from February to May, about 100 participants. Some of the motivations remain roughly the same, but the big difference is obviously the COVID pandemic. Another big difference was instead of a mobile phone app, we said that Google is collecting a lot of these data already. So we requested the people, if they consented, to share their Google takeout data, which was a log of their personal data. And the data analysis, the interconnections are still ongoing. And the questions we are interested in is vaccination. So after vaccination, do people become happier, less stressed? Do they walk around more often? These are the kind of some of the initial questions that we are studying in this. I would welcome comments, questions, collaboration opportunities. This is my email address, and a big thanks to everybody who's part of the behavioral informatics. Thank you.
Thank you, Vivek. Okay, so we'll pass the mic back across the Atlantic once more, and we'll give it to Christos Diou. So Professor Diou is an assistant professor in the Department of Informatics and Telematics at Harokopio University in Athens. His research interests lie in the areas of artificial intelligence and machine learning with an emphasis on their health-related applications. He has many publications in international journals and conferences, and is a co-inventor in one patent. He's currently the PI for a project called Rebecca, which I believe is a Horizon 2020 funded project at Harokopio that focuses on using real-world data and AI for improving the quality of life of breast cancer patients who have undergone their primary cancer treatment. without further ado, Christo, we're all ears. Go ahead.
Thank you very much, Matthew, for the introduction. I think my presentation follows up very nicely after Vivek's presentation. I'm going also to discuss machine learning for objective behavior measurement and also discuss its potential in improving health communication. And we will do that, I'm sorry. Yep, okay. We will do that through examples of relevant research in measuring eating behavior, in linking population behavior with the urban and social environment, as well as in using real-world data for improved communication in clinical research for complex chronic conditions. First, starting from individual eating behavior, the reason for doing that is because eating behavior is traditionally reported, self-reported through questionnaires, but these have been shown to be notoriously inaccurate. And also, there are many aspects of behavior that are useful, the microstructure of behavior, like, for example, how fast one eats, that cannot be self-reported. So to address issues like this, we have looked at the problem in various viewpoints. One way we did that was to develop an algorithm for measuring intake using a smartwatch. And the idea is that we break down intake motions, that is, putting mouth in your food in your mouth, through it to micro movements, which are simpler motions, and try to identify those, and then identify the sequence of micro movements as intake, action, or node. But what we found, and this is not something new to machine learning researchers, is that we can also approach this problem in an end-to-end way and try to have the algorithm actually learn to decompose intake gestures into simpler movements. And so we found that end-to-end algorithms work just as well, even better, with algorithms based on micro movements. And we achieved satisfactory scores both for detecting bites during a meal as well as detecting meals. And another similar project also reached similar conclusions. We also were involved in the development of a chewing sensor. This is a device that you are wearing during, for example, the afternoon, and through algorithms, it would count the number of snacks or meals that you had during the afternoon, which is a real issue for some people, including myself. And here, the idea is that we have multiple signal modalities that are processed, and initially we developed algorithms that extract features from these signals, fuse them together, and perform the detection. But again, after developing deep learning algorithms and representation learning algorithms for doing the same work, we found that these actually work better using only one modality. So again, we achieved satisfactory results for meal detection using one modality only. Again, the same conclusions. So why is this useful? This can facilitate communication between patients and health professionals. And actually the chewing sensor was used by overweight young adults to improve consultation sessions with dietitians in the Netherlands. And also, of course, it can support research to better understand the relationship between health and eating behavior parameters, which have been found to be linked both with overweight as well as eating disorders. So moving from the individual to the population level, another question is that how can we use population measurements of behavior to objectively link local environment with behaviors like low physical activity, unhealthy eating habits, etc. So to do that, we were involved in a project called BigO, which developed a smartphone application and a smartwatch application to continuously monitor children and adolescents in terms of their behavior, and also allow for self-reports and pictures to collect data, and combine those with external data sources, like, for example, GIS data or data from statistical authorities, to support a number of applications. Some were educational applications for children to realize how their behavior affects their health, clinical applications for patient consultation sessions, the general public, and also policymakers through a public health authorities portal that shows indicators of behavior and the environment and helps reach evidence-based decisions. So the idea is that we have several measurements, we call them indicators, which include, for example, steps, activity counts, and more detailed indicators like weekly visits to fast food locations, physical activity after school, etc. And then we also have local environment measurements like the availability of parks, green spaces, number of cafes, fast food restaurants, athletic sports facilities, etc. And these are all visualized in a dashboard, which allows to get insight and decisions about policies. So we had several contributors participating in the study. There were over 5,000 children, and this led to the collection of quite a large data set that we are still currently analyzing to reach some results. And of course, when displaying the data, these are aggregated at geographical level to ensure privacy. So I will show 3 examples of the use of this system. These are not, of course, conclusions that can be used in the as scientific results, but there are just indications of what you can do with a system like this. So these are screenshots of what was happening in autumn 2019 in the city of Stockholm. This is the city center, and this is the steps per hour indicator. And this is autumn 2020, so it's before and after the COVID outbreak at the same time of year. And we observe an increase in physical activity and a reduction in food-related visits in this area. And this happens despite the fact that Sweden was not on lockdown. I'm sure you're aware. So another application is to observe differences between 2 locations in the same metropolitan area. This is the Thessaloniki metropolitan area, it's a city in Greece. And these are 2 municipalities, and we observe a significant difference in behavior in terms of visiting patterns to food-related locations. And these can be explained in terms of both the urban characteristics of these locations, but also in terms of the socioeconomic status of the people living in these areas. And another example of interesting correlations that we found was Larissa. We found a positive correlation between cafes and the number of steps of children. And initially this is surprising, but if you realize that Larissa has a large pedestrian zone in the city center, which is full of cafes, then this becomes more clear why this happens. So people visit this pedestrian zone to socialize, but they also walk more in doing that. So systems like this can support evidence-based policies, in this particular example against obesity. We can also measure the impact of policies, and more interestingly for us, it can help build data-driven models for understanding the relationship between obesity and the local environment. But of course, there are many challenges to be solved in doing that. We will discuss this a little bit later. And finally, Matthew already mentioned that. I would like to present the project that is just starting here at Harokopio. It's called Rebecca, and the goal is to better understand the quality of life determinants for women who have undergone the first-line breast cancer treatment. So women, after the primary cancer treatment, undergo a conservative treatment that is long-term. It is for a lot of years, and it has many side effects, both the original treatment.
3 minutes.
Thank you. This is not very well understood in the clinical literature. Most of this relies on self-reported measures we call patient-reported outcome measures. So our ambition is to build a system that combines multiple sources of information, including health record data, environment data, retrospective data sets from registries and other sources, as well as, of course, patient data, including objectively measured information as well as self-reports. And our ambition is to build a causal model in identifying cause and effect relationships between some of the variables, which hopefully will allow us to build personalized care plans and also help in advancing clinical research in the area. And the reason you want to have a causal model here is because these are observational data and you want to avoid confounding issues, biases, etc. So if we achieve this, then we develop both methods, but also hopefully results in associating, identifying the quality of life determinants for breast cancer patients. So to conclude, we have identified, we have discussed a little bit about how behavioral measurements have the potential to improve both patient monitoring, but also communication with health professionals. And here representation learning is key. And moving up to population level, we have seen how behavioral data can support evidence-based policies. And here the challenge is to model relationships between indicators of behavior and the environment. And of course, this can also be translated in data collected in uncontrolled conditions in clinical research to better understand multifactorial chronic conditions. And there are several data challenges. I think Vivek also mentioned some of these, so it's very interesting to see other viewpoints of the same problems. So thank you very much. Hope to have a good discussion later.
Thank you, Christo. Some fascinating data and approaches to serious and unfortunately problems we haven't managed to solve from a health perspective. I'm going to turn the mic over to Riva to briefly introduce our next speaker and colleague from Rutgers, Srishti Raval.
Good morning, and thank you all so much for your interesting presentation so far. Srishti is an assistant professor in our Department of Clinical and Preventive Nutrition Sciences in our school, and she's also an adjunct assistant professor in the School of Public Health. She received her PhD from the University of Connecticut and did a 2-year postdoc at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Her research takes a life course epidemiologic approach to look at the nutritional and biopsychosocial risk factors of cardiometabolic diseases. So Srishti is going to present some of her work today in looking at a mobile health application for management of gestational diabetes. I'll turn it over to Srishti.
Thank you so much, Riva, for the introduction. It's my pleasure to be invited to this symposium, and I'm really excited to share with you some of the work that we're currently doing in Nepal in terms of developing and testing a mobile health application for management of gestational diabetes. So for those of you who may not know, gestational diabetes is diabetes with first onset or recognition during pregnancy, and it is one of the most common pregnancy complications. The prevalence of gestational diabetes is increasing worldwide, particularly in low and middle income countries like Nepal. So Nepal is actually geographically situated between the 2 epicenters of the global diabetes epidemic, which is India and China. And although we don't really have good population-based data, few population-based studies have reported GDM prevalence rates ranging between 2 to 8%. So these high rates of gestational diabetes and the fact that it's increasing is alarming because gestational diabetes is associated with several adverse health consequences, including increased risk of type 2 diabetes and other cardiometabolic diseases in both the mother and the offspring. So studies have shown that it is possible to reduce the risk of adverse pregnancy outcome for women with gestational diabetes if we can treat it and manage it in a timely manner. The goal of gestational diabetes management is basically to keep the blood glucose levels in a healthy range. And that is usually done by regular glucose monitoring, making appropriate changes to the diet and physical activity, and then using medications if necessary. But regardless of whether or not the patient uses medications for gestational diabetes, diet and lifestyle modification is still a very important part of gestational diabetes management. But finding adequate time for diet and lifestyle counseling is very challenging in a resource-limited setting like Nepal. So this is where mHealth technology can be leveraged because mobile phones can give us new opportunities to provide education and promote healthy diet and physical activity among patients with gestational diabetes. In Nepal, data shows that nearly 73% of women of reproductive age use mobile phones. And in 2019, when we surveyed a sample of 100 women who were receiving antenatal care in our study site, which is Thulikal Hospital, we found that 100% of women own smartphones and 90% use internet on their phone, which was a good indication for us that a gestational diabetes app may be useful in this population. So with that in mind, our pilot study had 2 aims. So the first aim was to develop a mobile app that supports self-management and treatment for Nepalese GDM patients. And the second aim was to assess usability, acceptability, and preliminary efficacy of this app. And the study is being done in Dhulikhel Hospital, which is the University Hospital of Kathmandu University in the city of Dhulikhel, Nepal. So we took a user-centered design in developing the GDM app, meaning that we focused on the potential user needs as well as incorporated their feedback in each phase of the app development process. So the study is still ongoing, unfortunately, due to COVID, we've had a lot of delay, but we've completed some of the initial steps, and this figure here shows the flow chart of our study design and protocol. So first, we made a paper prototype of the app we wanted to design, and then we did initial user research with GDM patients and the providers to get their input and feedback on the app. And then incorporating these findings from the user research, we finalized the app features, and we've started the app development process already. The next step after we have the app ready is to do usability testing again with GDM patients and then make any other changes that we think are required. And when we have the final version of the app, we will test the efficacy of this app in a clinical trial, which I will describe in a little bit. So this is the app prototype we came up with. So of course, the primary goal of our app was to provide education and resources for GDM management. And a lot of these education materials we developed ourselves for inclusion in the app. In terms of other app features, we decided that the app should support patients in self-management of gestational diabetes by helping them to set reminders for clinical appointments, as well as allowing them to record and track their blood glucose levels, carbohydrate intake, weight, and physical activity. So the physical activity would be recorded automatically through the sensors that are embedded within our phones, but the glucose levels, weight, and carbohydrate intake, the patients would enter manually into the app. The app would then generate a graph summarizing patients' diet, physical activity, and weight and blood glucose patterns. And the idea behind this was that the graphs would make it easier for patients to self-monitor their health and track their progress over time, and also understand whether or not their glucose, weight, or physical activity are meeting the targets and recommendations. So this graph, for example, was our prototype for the glucose graph, and it shows the average weekly glucose level from 24 gestational weeks, which is when typically gestational diabetes is diagnosed, to 40 weeks of pregnancy. And the bar graphs are color-coded so that the patient can quickly see how many measures were green and normal and how many were red and thus above the recommended glucose targets. The patients will also have the ability to share these graphs with clinicians through the app, which will help the clinicians to quickly understand the treatment progress and may additionally help them to make changes to their treatment and counseling accordingly. So for the carbohydrate tracking feature, we compiled a list of common carbohydrate food sources in a staple Nepalese diet, as well as pictures of commonly eaten portion sizes of these foods. So in the app, the patients would be able to select from a list what foods they ate for each of their meals, and also how much they ate by selecting the closest portion size, either from a list or from a set of pictures like shown here. And based on that, the app would automatically display how much calories and how much carbohydrate they consumed for each of their meals. So after finalizing this app prototype, we also conducted a focus group and interviews with GDM patients and providers to seek their feedback about the app, about the prototype that we had developed. So in total, we spoke with 6 GDM patients, 3 family members, and 5 healthcare providers, and these included 3 OBGYN physicians, 1 nutritionist, and 1 physiotherapist. So basically, we asked them mostly for the feedback on education materials we had developed. So we wanted to make sure that they were adequate and they were easy to understand. We also asked them to look at the various graphs. So for example, for the glucose graph, we wanted to make sure that the patient and the providers could easily understand and interpret the trend and the numbers on the glucose charts that we had designed. And lastly, we also asked, if they had any suggestions on how to improve the
3
app
minutes remain.
and suggestions for any additional app features that we should include. So in the interest of time, I'm not going to go into all the findings in detail from our user research, but overall the feedback was very positive. We also got a lot of suggestions on the app, and the slide here shows lists some of them. So of course we didn't incorporate all of these into our app due to budget and time constraints, but there was quite a bit of suggestions that we were able to incorporate. So taking in the suggestions, the app is currently in development. The next step after the first draft of the app is ready is to do usability testing again. For that, we will recruit 6 additional GDM patients. So actually 6 patients who either had GDM previously or have GDM in their current pregnancy. And we'll ask these patients to perform several tasks on the app. So for example, we might ask them to use the app to enter their last blood glucose levels, or to use the app to find out how much carbohydrate, for example, is in a piece of bread. And basically we'll take notes on how easily and successfully the patients were able to do the tasks that we asked them to do, and where can we make any changes to improve usability. And at the end of the test, we'll also administer questionnaires on basically to ask patients to get their feedback on the app's usability and how we can improve and make it more useful and relevant for them. And if time permits, we'll also do another focus group with these patients and maybe one more round of usability testing before we finally finalize the app that will be tested in a clinical trial for aim 2 of the study. So for the clinical trial, we'll recruit 60 women who are newly diagnosed with gestational diabetes in the Tulifil Hospital and randomly assign them to 2 groups. So either the GDM app plus standard care or the standard care alone from 28 weeks of gestation to delivery. So those who use the app will use the app for 12 weeks or 3 months, and we will assess the outcomes at delivery and at 6 weeks postpartum. So
1 minute remains.
So there are basically 2 types of outcomes that we're interested in. So first, among those who use the app, we want to know whether or not the app was useful and engaging. So to do that, we'll look at outcomes such as app usage and self-monitoring adherence. And these are, these will be based on things like how many times they open the app, how many times did they watch the educational videos, how many glucose entries there are. So all of these things we can assess directly from the app itself. And second, and more importantly, we want to see whether or not the app improves the treatment outcomes. And for this pilot study, the main treatment outcomes are neonatal birth weight, cesarean delivery, labor induction, and glucose levels at 6 weeks postpartum. So since the sample is so small with only 60 women, we don't think that we will see statistically significant differences, but we do hope that we will see some indication of improvement in this pilot study, so that we can use the findings from this pilot study to design a larger clinical trial in the future. So ultimately, the goal of this app is to empower women with gestational diabetes to self-manage and improve their health by providing them with the resources they need from their own mobile device, as opposed to just relying on only the care that they receive from their healthcare providers. So if successful, the implications for this work is immense, especially in the context of low and middle income country like Nepal, where the type 2 diabetes epidemic is escalating. Proper gestational diabetes management is critical because not only is this the earliest time point that we can intervene, but it's also a way for us to disrupt this intergenerational cycle of diabetes and have a shot at curbing this epidemic in both women as well as subsequent generations. So I'd like to end by thanking my co-investigators and my research team, and also the NIH Fogarty International Center for funding and supporting this work. And thank you all for listening.
Thank you, Shristi. Well, I'm going to turn it back over to Matthew to go back across the other side of the ocean.
Okay, so thank you, Shristi. I'll go to, and I think we have a last but not least presenter. We have a Kostas Tserpis from Harokopio will be presenting for us, and Christos will give us a brief intro to Kostas's work, and while Kostas is setting up work, is already set up and ready to go. So Christos, go ahead.
Yeah, our last speaker is Professor Konstantinos Tserpes. Professor Tserpes is an associate professor at the Department of Informatics and Telematics of the Harokopio University of Athens. His research interests include software and service engineering, cloud and edge computing, and machine learning applications. He has been involved in several EU and national funded projects dealing with challenges related to scalability, interoperability, fault tolerance, and extensibility in several application domains, including e-health. He has served as the scientific or general coordinator in several information and communication technologies projects, where he has coordinated software development teams and has acted as the chief software architect. Konstantinos, you have the floor.
Many thanks for the introduction. Sorry, I was looking for the mute button. Things interface changed and I wasn't prepared for that. Okay, so I was, listening to your presentations, which were great, and I could understand that we're discussing and we're highlighting the value of health communication as a single directional process in a way, and we tend to not talk about the other way around. So we're talking mainly about how the research done from us, the researchers, should be communicated to experts, community, and so on. But what I would like to do is to grab this opportunity and talk about the other direction. Talk about how it is important to, to see health communication as a bidirectional, a full duplex bidirectional process, where you need to hear exactly what are the needs of the application that you need to solve, and somehow motivate our research towards the right direction. So my presentation is more like an anecdote story to highlight this kind of importance. So I'm using as an opportunity work that we've done with my colleagues Antonios Makris and Ioannis Kontopoulos about a year ago. Research work that we done and that we published in a conference. So hold on, let me see how I can. Yeah, all right. So if you read, the motivation of the paper, if you read between the lines, is basically to save the world. This is the thing that we're saying. So, but the real motivation, if you, at that time, was mainly because we found a data set that had to do with COVID-19. COVID-19 was the hot topic. We thought that, okay, cool, if you make a publication like that, maybe we can accumulate some citation from our work. And, everybody's doing it, so why not us, right? Okay, jokes aside, the thing that we were trying to do is we're trying to develop a mechanism that would be able to, classify an X-ray image that of a person that was affected by pneumonia in COVID-19 related pneumonia or bacterial pneumonia. So we added one more class in the mix that was of healthy people, right? So people that didn't really have, at least they weren't infected by, they hadn't presented, symptoms of pneumonia. So that was the main idea. And the thing that we were trying to do is to use deep learning, machine learning, to figure out whether we can create a classifier like that. And what we've done is that we actually went through numerous neural network architectures, especially convolutional neural network architectures, to figure out whether we can find something that would fit the purpose. We realized that we had a problem at the time and a kind of challenge, and the challenge was that we had a really small data set in our hands, and we needed to find a way for a model to converge even when the data was as small as this one. So, yeah, where the data set came from. So it was a data set, open data set from a couple of sources. We mixed that and we created, as I said, a bigger data set, which we had to balance, right? Because it was rather skewed. There were more people that had, in our data set, there were more people overrepresented. One class was overrepresented. So we had patients, right, with confirmed COVID-19 cases, so X-rays of their chest, of their lungs, that were confirmed COVID-19 cases. We had people that were presenting pneumonia symptoms, but that was kind of what's called a common bacterial pneumonia. And we had also, normal incidents, so healthy people. So, as I said earlier, we had this to tackle this challenge that the data set that we ended up was really small, right? So what we did is what it's kind of common approach. We employed a technique called transfer learning. The idea was that we used a trained neural network, and then we removed, let's say, the last layer, the kind of the layer that makes things different from one network to another, and we did all the training. We freeze the other layers, and we did all the training for the last layer, for the new layer that we added. That saved us from training time, but it also really helped us into dealing with the small data set problem, because we were basing our work on a well-established network architecture, and that was already trained. So what we did then is that we used numerous such architectures, and we followed this technique that I mentioned earlier. We use CNN because CNN are mostly used for classification when you have images and such like media to process. So that was the main idea. So what we tried to do is to see which of those models that we were training, once they converged, what was the highest values in terms of accuracy, right? So we ended up with some figures that you can see the paper, but in general the VGG16 presented the best results, the best overall accuracy. We used other metrics to figure out, because it was kind of important to understand, not only the true positive but the true negatives in such a technique. But all in all, we ended up with with a network that actually did the job with a really good accuracy. It could tell by processing an X-ray whether a patient had was affected by COVID-19, by SARS-CoV-2, sorry, or whether that was a case of pneumonia, or whether that person was perfectly healthy. So we were really glad about that. It turns out that in the peer review process, the reviewers were glad as well, and this work was published. And then we thought that since we did that, since we really thought that this was really good work and something that could make a difference, we went and talked to some radiologists, some people that were experts in checking this kind of X-rays, these images, especially when it comes to COVID-19. So we went to Athens Reference Hospital and we talked to those people. They found some time to talk to us. We presented our findings, explained how this thing worked and how we could turn this to a software tool that could help them. And it turned out that that was not really of help to them, because the kind of findings that our algorithm could find, our model could find, was the ones that they could find, by just looking at the image. That was
3 minutes remaining.
Thank you. Sure. So the other thing that we found out is that they were, it wouldn't be safe just looking into the spots that our algorithm was isolating, but there were other criteria that one needs to take into consideration, which we didn't, of course. And so that was not really useful to them. What would be useful to them, perhaps, is that if we could distinguish COVID-19 pneumonia from H1N1 pneumonia. And also, among others, they also told us that, you're using X-rays that they're in perfect shape. The kind of X-rays that we are getting from various places, medical centers and so on across Greece, their quality is really low. There's a lot of noise in there. So it will never work, the thing that you made. So it was kind of sad to us, though they gave us new problems to study, and that really, and we are currently studying those, and that really, was a kind of hint to me that probably this is something that people would like to hear. That you need to really ask the right questions before you start your research, and in order to do that, you need to talk to the people, to the medical experts, or to the patients, or the people that are interested in that, and they have to give you the right requirements, and that will motivate the research work. So if you start doing research work just for the sake of it, in a way, this is what we've done, to be entirely honest. Even if you have the purest intentions, you might end up into something that is not of value, really. And if you are to make an impact, you have to use this health communication process as a bidirectional process, not a single directional process. So that were the things that I would like to talk about today. If you feel that there's something interesting there, then you'd like to contact me, feel free to use these details. Thank you very much. It's been a pleasure.
Thank you, Kostas. Okay, great. So we have 5, I think, great presentations with took us in a few different directions in terms of health issues, ways to think about technology and communication in health context. We have a little bit of time for conversation and questions. While our audience, sort of wraps their head around the issues that have been presented, I'd like to ask our reaction panel members to see if they have any comments or questions that they'd like to share with the presenters before we move on. And so among our colleagues who are on the reaction panel, we have Laura Byham-Gray from Rutgers, and Shankar Srinivasan. Jean-François Dano is also here with us from Rutgers. And from the other side, we have Iraklis Varlamis with us. And who am I missing? Christo.
It's Yorgos
Kouskouris, right. So we have 5 colleagues with us. Anybody feel they'd like to ask a question first or comment on anything that we've heard so far?
Well, I'll be happy to start. I'm Laura Byham-Gray from Rutgers. And this question is to Christos, because I'm very interested. I'm a nutritionist by training, work predominantly with chronic kidney disease. And I'd love to understand a little bit more how you use the sensors for detecting eating behavior. Obviously, we could look at it in pathology, but also in terms of treatment. And has this been used at all in children?
Right. Thank you very much for the question. We have developed 3 methods for measuring behavior, eating behavior, and I'm guessing you are more interested in in-meal eating behavior, but also tracking the different meals. One method is the smartwatch-based one, where the idea is that you wear the watch in your dominant hand, and the smartwatch, all smartwatches almost, carry a triaxial accelerometer, which is measures force acceleration in 3 directions, and also a gyroscope, which is also 3-dimensional signal. So you have in total 6 dimensions and continuous sampling of these signals in these dimensions. And then these signals are processed to, there's a quite complex way of pre-processing the signal before you use it. But then after pre-processing, actually, we were not able to initially to build an algorithm that would actually detect the bites. After that, we tried to separate a complex intake gesture, like pick up the food from the plate, then move the hand up and put the food in your mouth, etc. This we split it down into micro movements and trained a model, a machine learning model, by labeling the micro movements through video. So we had video recordings of people eating, and then we annotated every micro movement in order to train the algorithm. And then the algorithm detected the distribution of micromovements, it is the probability of each micromovement, and based on that, it was able to identify the intake. But then we also found out that it is possible to skip this annotation step and just annotate the points where someone ate. And the algorithm would also work correctly through representation learning. And that's what we did. So it turns out that it has an F1 score of about 0.92, which means that approximately we can say that it has around 92% precision and recall for bytes, which for us is good enough, but of course it would be nice if it could become better. And the other two methods is the method for the chewing sensor, and another was an algorithm that I didn't show that was developed for a plate scale. It's called the Mandometer. It's developed by a company in Sweden. It's Mando Clinics, and it is used for the monitoring and treatment of eating disorders. So again, there was an algorithm that we developed there. And regarding its use on children, no, we have not used these methods for measuring eating behavior of children. I don't know if I answered your question.
Thank you. Yeah, no, that was great. Thank you. Very interesting.
Thank you, Laura and Christos. Other comments or questions from our reaction panel or from our broader audience?
Yeah, I can go next.
Please.
I mean, it's not directed at someone specifically, but one of the issue with machine learning models is the reproducibility, right? So depending on your training set and the parameters that you're using, the results of your model can vary quite a bit. So how far do you think we are from being able to use this for diagnostic purposes? Because obviously you don't want to tell somebody that they have cancer or they have Parkinson's disease if they don't have it, right? So, how much work is there that still needs to be done before we can use this in clinical practice?
I can try and share my opinion. I don't want to speak all the time, but I actually, this is a problem that is very interesting for me. I think that we are not close to that yet, to have models that you can safely say that they will generalize in data sets with different distributions, or when you move from even one machine to another, which has different properties. So I think this is one research challenge that needs to be addressed if we want to see AI in healthcare and AI, for example, also in other safety critical applications like self-driving cars. And I think this raises a very important issue that there's a lot of research going on that domain, but I think we're not there yet.
Anyone else want to take a stab at answering Jean-Francois' question, or is there another question? Oh, go ahead.
I have a question. Yeah, I have a question to Ms. Raval concerning the work that they did with the patients, the diabetic patients. I was wondering if you have evaluated the commitment of the patients in using the app, or the intent of the patients to use the app, because what we usually face in similar intervention is the reluctance of people to use such applications, to be consistent in filling up the forms and everything. So have you examined this?
Yeah, when we did the initial focus group, that was one of the things that we had asked, and we asked this question to both providers and patients. So the primary users are the GDM patients, but we also asked the doctors if they would be willing to recommend it to their patients. Yeah, we got really good feedback that they would be willing to use the app, and some of the patients even said that they wish they had this app earlier, and it would have avoided a lot of hardships that they faced, and lack of information that they faced. So they were really excited that this app was being built, and they said that they would recommend it to any of their pregnant friends who have gestational diabetes. But I think the idea is that I think the willingness is there, but the problem is engagement, right? So I think that's where we need to focus later. So even if the intention and if they're willing to use the app, whether or not the app is engaging and whether we can retain users is something that we'll kind of get an idea from this pilot project, and how we can improve that will be sort of like one of the things we need to tackle.
Good, good. Thank you.
Thank you.
Okay, other questions, comments from either our reaction panel or from anyone else?
Thanks. I just wanted to congratulate all of the speakers. I only wish they all, we had time for each of them to speak in depth. It was too short a time to really get to know the intricate details, but I really liked every one of them. I just wanted to say that out.
Thank you. Other questions or comments from anyone?
I would have a question.
Please go ahead.
So, thank you all for the nice presentations. My question is a bit general for everyone, and it is in line with what Kostas mentioned. Especially for the people that come from the health domain, I would like to inquire what are the challenges you face with different let's say technologies. What would you need to do your work easier in terms of platforms, services, functionalities, for example, processing of data, storage, or whatever? So are there any, let's say, points that you could give to, let's say, ICT people for building better services that could help you?
Any thoughts from our colleagues from the health professions?
So for me, I think that with this is my first sort of mHealth project, and it's really important to have a good team, because there's a lot of things that you don't know. Almost everything was like new to me about mobile technology. I think for me, it would, and I don't know whether this is possible, but it would have been nice to have we had to rely a lot on external contracts to develop the app, and we had to we started work with someone else, and we ended the contract when we went to with the second company. So if there was in-house, a lot of this capabilities were in-house at either Tulipil Hospital or at Rutgers, I think that would have made things a little bit more faster, I feel, and maybe a lot more smoother. Because the app companies don't think from a research point of view, and there's a lot of breakdown as well. Personally, I feel like that would have made things easier for me. That's one of the things that I would like to point out.
Thank you, Srishti. Any other questions? I do see a question in our chat. For everyone in the panel who can answer, there's a general tendency in healthcare to individualize treatment and management. How does AI address this issue, since I guess AI is based on more or less forming general patterns rather than individualized patterns?
I'll take a stab at that.
Please go ahead, Vivek.
So AI comes in multiple variants, and I guess you are right that most prominent form of AI is look at 100 people, and then for 101st, you try to predict that, hey, you would be similar, right? So in that sense, it's generalized. Then again, there are multiple variants. Some of them which focus on the individual, some which focus on the groups. Also, there are things like transfer learning, or that each one of us is, part the population and part individual, right? So combining those two aspects is often the goal. Also, what you can do is if we have enough data about each individual, like the way you walk and talk and, very rich understanding for an individual, you can train things on an individual sample. There's also this notion of digital twin, or something like traditionally you would have a very hard time finding somebody who's exactly the same as you, but varies on just one parameter, like that's the traditional A/B testing model. But when you have millions and millions of samples, it is more possible. Again, there are some limitations with any of these approaches, but it's more likely that you can find somebody who's exactly like you, but varies only, let's say, in one dimension or things like that. So there are different variants and people are investigating this. This is an open issue, but there are lots of people trying to tackle this exact issue of personalized medicine using large-scale data and analytics.
Yeah, and I think that's where the direction, like, the intersection of mobile health and precision medicine, right? So you can get a lot of data from, mobile devices that you can use that, and you can use AI and big data technology to, personalize the feedback that they get, or even personalize the intervention. I think, that's one of the areas that we're heading towards.
And also, if I can also comment, then you can, just a thought in case you have some experience with machine learning, for example, a sample can be an individual, or as Vive pointed out, it can be repeated measurements from the same individual. So you can learn the patterns of a particular person. So this is also a way to think about that. And since I've taken the speech once more, I also have a few questions, if I am allowed, Matthew.
Yes, please go ahead. We have a couple more minutes. We're running a little bit over, but I think we started later too. So we have like 5 more minutes to go. So go ahead.
Okay. So one very interesting, this goes to Vivek regarding the measurement and assessment of mental health. And the question is, have you, in your studies, did you consider text from social media posts as an indicator of, have you done that? If you can comment a little bit on this, please.
Sure. So in at least the last round, we did not. And there were two good reasons for it. One was there is existing literature which was already connecting the dots over there. Two, we were asking for very sensitive data, and we thought that we will make an explicit promise to our participants that we look at only the metadata of their communication rather than like the actual content. So how many people, what hours of the day, frequently or not, those were the kinds of features we decided to focus on. Having said that, there's no confusion in my mind that like the text, the social media kind of text would be very relevant. Work by Munmun De Chaudhary and group, if you're familiar with that. There are lots of people who are doing some amazing work in that space as well.
Right. Thank you.
Okay. I think we reached the end of our time. Unless there's any other burning questions, I think we can bring this session to a close and promise to come back with more as our collaboration unfolds and progresses. I'd like to thank everyone who was here today, our presenters, our reaction panel members, our co-host, my co-host, Riva Tagore-Decker, Rector of Harokopio, Professor Mayra Nicolaidou, and of course my colleague Christos Diou as well. We say goodbye to all of you for now. And if you have any questions or want to follow up with what we're doing in the future, please reach out to us. In the meantime, if you have a moment, please take a moment and complete the evaluation form for the event, which I've posted in the chat. And particularly for those of you that may be students, and I know this may matter more to them, if you'd like a certificate of participation in the event, there will be a link to how to get to that, at the end of the evaluation form. The evaluation form is anonymous. And so there's an additional link that you need to use to ask for the certificate by name. So thank you again to everyone. Have a good day or good evening, and we'll stay in touch. Take care. Bye-bye.
To those of you who are joining us for the closed session, please use the second link and we'll see you at 10:45.
Okay, sure. Yes.
Or 5:45 in Athens.
5:40.
Bye-bye.
Pick your time zone.
Thanks.
Thank you very much.
Thank you, everyone.
Yeah. See you
Goodbye.
soon.
Thank you for attending.
See you soon.